Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of MRCP within the last 5 years and want to help you do the same. We are not associated with any MRCP examination organisations, and the materials covered are by no means an exhaustive list of what can come up in your exam, or indeed medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic,
which is Bullous Pemphigoid, part of our Dermatology revision series. So what is Bullous Pemphigoid? This is an autoimmune disease which results from IgG binding to dermoepidermal junction. This then leads to dermoepidermal separation and blisters. The target antigen in most cases is type 17 collagen. Bullous pemphigoid can occur at all ages, but most commonly occurs in the elderly. It can also be associated with pregnancy. It's the commonest immunobullous disease in Western populations. Initially, an erythematous urticaria-like plaque occurs, and this results in tense blisters. It has a generalized distribution. Bullous pemphigoid is particularly common on flexor surfaces, and an example in the picture here can be seen on the trunk and neck. History and clinical examination is key. The skin biopsy will show blisters at the dermoepidermal junction. Direct immunofluorescence will show IgG and C3 along the dermoepidermal junction. Serum for indirect IgG bind to the dermoepidermal junction of normal skin. Finally, the full blood count may show a possible eosinophilia. Treatment of this condition is with topical and systemic corticosteroids, and this can be with or without adjuvant drug therapy, for example with azathioprine. Complications of this condition include skin infection, which can lead to septicemia. The prognosis includes significant treatment-related morbidity and mortality, but ultimately the condition may remit. So let's try a question. A 60-year-old lady presents with a few weeks' history of tense blisters affecting her arms and sparing her mouth. Her blood test shows evidence of eosinophilia. A diagnosis of bullous pemphigoid is made. What is seen on the skin biopsy? So as we said before, skin biopsy questions can be quite common in MRCP questions, both in part 1 and part 2. So the options here are neutrophilic infiltrates, blisters at the dermoepidermal junction, lymphocytic infiltrates, IgA against the dermoepidermal junction, or C4 along the dermoepidermal junction. The correct answer here is blistering at the dermoepidermal junction, as you may recall from an earlier slide.
Thank you for listening to this episode of Bite-Sized MRCP. If you like what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure you don't miss our next episode. Let us know in the comments which topics you would like to hear in future. See you in our next episode.